Hello everyone, welcome back to LdL. Today I saw, today I learned. I am Dr. Adarsh Pal and today's topic is one that walks into almost every OPD every single day. A patient sitting across from you saying, "Doctor, I keep hearing a ringing in my ear. It never stops." So that is tinnitus. And while it sounds simple, just a noise in the ear, once you dig in you realize it can point you towards anything from an ear problem like earwax to an intracranial vascular malformation. Today we'll discuss 3 real cases to understand the concept. By the end of this video, you will know when tinnitus is benign and you can reassure the patient and when it needs urgent ENT or neurological referral. So let's discuss the first case. Priya is a 38-year-old teacher who came worried about a ringing sound in her right ear that just won't stop. And she says it is loudest at the night when everything is quiet and it has been going on for 6 months. The tinnitus is high-pitched, constant and non-pulsatile, not beat with her heart. And she works near heavy machinery and she also has lost hearing in the same ear in which she is experiencing tinnitus. And there is no vertigo, no ear pain, no ear discharge and no facial weakness. So what do you think is the most likely diagnosis? First, noise-induced sensorineural hearing loss with tinnitus. Second, Meniere's disease. Third, acoustic neuroma. Or fourth, pulsatile vascular tinnitus. The correct answer is A, noise-induced sensorineural hearing loss with tinnitus. Let us understand why. So, loud noise mainly affects the base of the cochlea where the high frequency generated. So, when those hair cells die, the central auditory cortex does not go quiet, it goes noisy. The brain starts generating phantom sounds to compensate for the missing input, and that is tinnitus. It's similar to a phantom limb for the ear. So Priya's 6 months history with an occupational noise exposure and the hearing loss in the same ear is suggestive of noise-induced hearing loss. You should always ask about the occupation in any tinnitus patient, like whether they are factory workers, musicians, construction workers, because it is the commonest reversible factor that we can counsel against. Let us understand the second option, Meniere's disease. In Meniere's disease, there are other features like vertigo, and the tinnitus is low-pitched, and there is a sensation of oral fullness. Vestibular schwannoma is also a good differential because it can also has unilateral tinnitus. It will have retrocochlear hearing loss on audiometry, and therefore any patient with unilateral hearing loss will need to do audiological investigations like pure tone audiometry and if needed MRI to rule out any unilateral mass lesion. It does not have any vascular tinnitus, which would usually present with a feeling of whooshing sound or ringing which is synchronous with the pulse. Whereas Priya's tinnitus is continuous, non-pulsatile and it has no positional variation. So let us discuss what we need to ask in the OPD for eliciting the etiology of tinnitus. First is character. Pulsatile tinnitus usually means that the cause is vascular. The second is unilateral or bilateral. If there is a unilateral tinnitus and patient also has hearing loss in the same ear, audiological cause or ear problem is the cause of tinnitus, which is causing both hearing loss as well as tinnitus. Then we need to ask about the duration and progression. If the tinnitus is present for a very much long time, then it is less concerning. But if a tinnitus has started suddenly and it has started with other symptoms, other neurological deficit, then it is concerning. And whether there is any history of noise exposure or ototoxic drugs. Ototoxic drugs include like salicylates, aminoglycosides that can cause tinnitus as well as hearing loss. We need to ask about other ENT symptoms like whether there is any hearing loss or vertigo or ear discharge, ear surgery. We also need to ask about any CNS symptoms like other CNS symptoms, any limb weakness, diplopia, dysarthria that may provide clue to the CNS cause of the tinnitus. So if there is no pulsatility present, it is less likely to be vascular cause. And if there are no focal neurological deficit, then we can be reassured that central cause is less likely. So what we need to look for in the examination, the first is otoscopy, then the tuning fork examination to look for whether it is sensorineural versus conductive hearing loss, then a CNS examination to look for whether there is other cranial involvement, then is auscultation of the neck and the mastoid area, the temporal area to look for any bruit. And if the patient says that there is a vascular tinnitus, suggestive of vascular tinnitus, like if he says that there is a whooshing sound and the sound becomes less or more on lying on one side or it becomes less on pressing the neck region, then it is suggestive of a vascular tinnitus. And we also can look for the palate inspection where palatal myoclonus, rhythmic movement of the palate can provide clue to the palatal myoclonus as a cause of tinnitus. Now let us see a different case. He also has the same complaint, however his tinnitus has a very different tail. There is a whooshing sound in his right ear which is present since 3 months. So the term whooshing should immediately trigger your vascular alarm. Pulsatile tinnitus that synchronizes with the heartbeat, worsens with exertion, and changes with head position is vascular tinnitus until proven otherwise. So the most common causes of this type of tinnitus is sigmoid diverticulum or dehiscence. So the venous blood in the sigmoid sinus can cause turbulent flow, and that patient can literally hear. And it can be confirmed by CT angiography, or it can be confirmed with CT with contrast of the temporal bone. So you can see an outpouching or dehiscent bone over the sinus. So the key question is ask the patient whether the sound varies with your pulse. Is the sound synchronous with the heartbeat? If it is vascular tinnitus, you do not send the patient home. The patient needs imaging, an MRI with a contrast, or CT angiography or venography to look for any vascular malformation, arteriovenous fistula, or sigmoid sinus dehiscence. Let us see this case. A 45-year-old male Suresh present with 4-month history of bilateral tinnitus, which is high-pitched, non-pulsatile, constant. However, he also reports 2-month history of other symptoms like rapidly progressive bilateral hearing loss, mild unsteadiness while walking, and diplopia on left lateral gaze. So he does not have just ear problems and tinnitus, he also has some serious, significant neurological deficits. MRI brain was done, which shows multiple T2 flare white matter lesions in a periventricular distribution. So what do you think it is? A. Multiple sclerosis, B. Bilateral vestibular schwannoma, C. brainstem glioma, and D. ototoxic drug-induced bilateral tinnitus. So the patient does not have any history of ototoxic medication. Also, the patient has significant CNS deficit. So D option is unlikely. Out of the 3 options, since the patient has T2 flare white matter lesions in periventricular distribution, which are suggestive of multiple sclerosis, it is the most likely cause. Multiple sclerosis can cause demyelinating lesions anywhere in the central nervous system, including the auditory pathway. This case is a reminder that we need to do all cranial examination and complete neurological examination, screening neurological examination in a patient with tinnitus to identify other neurological deficits, which might affect the management of the patient. So the framework in the OPD is simple. We need to ask simple questions, 3 simple questions. First is whether it is a pulsatile tinnitus or not. If it is a pulsatile tinnitus, it means we need to do vascular workup. Second, whether it is unilateral or bilateral. Bilateral with other neurological symptoms meet CNS, especially multiple sclerosis. And third, if there is an obvious cause like noise exposure or drugs or history of any ear discharge, obvious cause like noise exposure or drugs, and if it is chronic, you are likely dealing with a cochlear damage, that is an ear problem. Key thing to note is the urgency. Noise-induced hearing loss tinnitus you can manage electively if it is not sudden onset sensorineural hearing loss. Vascular pulsatile tinnitus needs urgent imaging, and neurological tinnitus needs urgent neurological evaluation and management of underlying disease. Let's talk about which investigations to order and when. For evaluation of auditory system, to look for the ENT cause, the first investigation is pure tone audiometry, which can identify sensorineural versus conductive hearing loss. And it can also tell about the degree and the frequency of the loss, like high frequency sensorineural hearing loss or low frequency. And then we can also autoacoustic emission test or BERA test. Autoacoustic emission test takes out the cochlear hazel function, which is absent in the noise-induced hearing loss. And if that is normal, we can do a BERA. If BERA is abnormal in the retrocochlear pathology like acoustic neuroma. If there is a suspected vascular cause of the tinnitus, if the tinnitus is pulsatile, then we need to do MRI with MR angiography or venography if we are suspecting dural AVF or sinus stenosis. And if we are suspecting sigmoid sinus dehiscence and paraganglioma, then CT temporal bone, high resolution CT temporal bone is required. So sometimes we may not get clue which is required. So sometimes both of these investigations might need to be done. And then the DSA, digital subtraction angiography, which is done by the catheter angiography, it is the gold standard test for the dural arteriovenous fistula if MRI and MRA are equivocal. And if we are suspecting a CNS cause of tinnitus, then MRI with contrast is required to look for MS lesions, like white matter lesions can be present in MS, or CP angle tumor or any brainstem lesions. And then depending upon the cause, we might also need to do visual evoked potentials or CSF analysis to look for any oligoclonal bands or delayed P100 latency in the VEP. And always we need to do a medication review to rule out any ototoxic drugs. The management of tinnitus, if the cause is identified, like if there is a vascular tinnitus due to sigmoid sinus dehiscence, then surgical repair would be required, or there is an arteriovenous fistula, then surgical or endovascular intervention would be required. And if a neurological tinnitus, underlying cause will need to be treated. If there is an ENT cause of tinnitus, then usually the management is conservative, like noise avoidance, treat underlying cause of the hearing loss like otitis media or otosclerosis, and tinnitus retaining therapy, cognitive behavioral therapy, these are done. Sometimes it is not possible to remove the tinnitus 100%. It might be these therapies might reduce the tinnitus so that do not cause significant dysfunction. And if there is an ototoxic drug, then you have to withdraw it. So let us discuss the key takeaways. First, if there is a non-pulsatile tinnitus and there is a history of noise exposure, significant noise exposure, and sensorineural hearing loss is there, then we need to think of noise-induced hearing loss, which is the most common cause in working age adults. If the tinnitus is pulsatile, then it is vascular until proven otherwise, and we need to gain MRI plus vascular imaging or CT angiography if we are suspecting sigmoid dehiscence. The third is tinnitus plus focal neurological deficit. Think of CNS cause and do a thorough neurological examination and evaluation. The key differentiator is pulsatile, which points to a vascular etiology. If there are bilateral plus neurological signs, it points to the CNS cause. And if there is a unilateral sensorineural hearing loss, then it points towards the auditory cause. Always review medications. Aminoglycosides, loop diuretics, and salicylates are the reversible causes. And the unilateral persistent tinnitus greater than 6 months needs an audiology plus MRI to rule out a acoustic neuroma.